Hey, good morning, everyone, and welcome to UroNurse. I'm your host, Vic Sinise. And yes, I'm not in my studio. If you noticed, I did say last week I was going to be traveling, and I'm in Dillon, Montana. So beautiful area to see if you've never been on this side of the country. It's really been pretty, a lot of good, great scenery. If you're watching us on any of our live ways that we can be watched, great, glad to have you on the show. And if this is your first time checking us out, be sure to check out our website at uronurse.com, the best place to go to see us all learn more about our show. And it's the best place to go to check out any of our past episodes. And boy, we got a bunch of them, 104 to be exact. Want to listen in your car? Hey, that's what I've been doing, listening to a lot of podcasts in my car on these travels. But you can go to the UroNurse Plus area and use any of your favorite podcasting shows and watch us or listen to us, I should say, every week. We got a great show for you this week. We've got a whole group coming in from SRS Medical, new sponsor to the show, by the way, and they're going to be talking about the UroCuff procedure. So we're going to learn more about that today. Let's go ahead and bring in all of our experts right now. Experts, welcome to the show. How's everybody doing today?
Good morning. How are you, Vic?
I'm doing good. So I'll kick it off with my introduction. For those of you that don't know who I am, I'm the host and producer of UroNurse, been involved in urology for the past 40 years. And this was my way of giving back to the thing that I've loved so much, nursing. Now, I'm going to share, since I am on vacation and I'm doing some going around the different areas of the country, I got a picture to show everybody here. So this picture is from the first one on the left side is from Seattle, and the person that you see in there is Vikram, who is the CEO and one of the founders of Pictory. Now, last week I was speaking about all this AI stuff, and Pictory is one of these AI devices that I use a lot of. And we had talked, and he said, "Hey, if you're in Seattle, let's get together." And we did. So it was great to get to meet somebody from one of the things that I use, software products. And then Susie Swain actually said, "Be sure I waved as I went through." Her area of the country in Washington. And I did. I actually stopped and bought some shoes there. So nice place to visit. All righty. Let's bring in somebody else to talk. Lori, go ahead.
Good morning, everyone. My name is Lori Atkinson. I'm a certified urology registered nurse. I have been in urology for 26 years now, currently working for Northwestern Medicine in Geneva and Winfield, Illinois. Glad to be here.
All right. Andrea, go ahead and give us your introduction.
Good morning, everyone. My name is Andrea Strong. I'm a urology academic nurse practitioner in Wisconsin. I've been working in urology for 14 years now, and I've done just about everything that there is to do in urology. Everything from working as a nursing assistant on the floor to now working at an academic center and running my own practice as a nurse practitioner. I'm also on the board of directors for the Society of Urologic Nurses and Associates. I'm the educational director for the Chicago Metro chapter, and I really look forward to today's presentation.
Great. And let's see who we have next here. Sarah, go ahead.
Good morning. My name is Sarah Bandura. I'm a nurse educator. I also have my CURN, so I have been in urology for 17 years now, and I've also done everything from being a call center to front desk to medical assistant to nurse and urodynamic. I mean, everything in between. So there's a lot there.
That's great. Okay, Angela, go ahead and give us your introduction.
Hi, I'm Angela Nodi. I work for SRS Medical. I integrate navigation programs or protocol-driven care. I do have pretty much my only background in medicine is urology. I've been in urology about 12 years or so. And urodynamics, I did that for about 5.5 years. Thank you, Sarah Bandura, for that. And so happy to be here. Thanks, Vic.
All right, great. And
hello,
Natalie.
My name is Natalie Meza. I work at Associated Urological Specialists in Tinley, or the Chicago suburb. I am the one that performs the UroCuff tests for our BPH navigation program, as well as also navigate patients that have BPH and get them in for their UroCuff test and hopefully have them move on to a third line treatment to make sure that their bladder stays healthy for the rest of their life.
Great. And last but not least, our speaker for today, David.
Good morning, Vic. Thanks for having me. I'm David Mahoney. I'm with SRS Medical. I oversee the clinical operations here as well as new business development, and actually worked on UroCuff for about 10 years now here. So been in urology for about 30 years of my life now.
Great.
Which means my entire life.
Yep. It's one of those fields, I think, that if you really get into urology, you're just going to love it, and you just never leave it because it's such a part of life. Hey, we got a lot of Chicago in the house. How many people are from Chicago raise your hands? Look at that. Lots of Chicago here today. All right. Well, we're going to get going with our show. I'm going to bring up your slides and then take it away, David.
Thank you, Vic. So, and thanks for letting us come on today and talk about the UroCuff test. This is from the clinician's perspective. So there's a lot to talk about as it relates to UroCuff and lower urinary and the application of UroCuff to the lower urinary tract spectrum. But in this talk, we'll look particularly at what it's like to run a test as a clinician. What are some of the tricks to get a smooth running program, and kind of what are the key elements to success? So it's from the clinician perspective. Wow, the formatting kind of went crazy when we uploaded this, Vic. So that said, when people come into the urology office here, in the United States, they're more than half the time they're there for lower urinary tract symptoms. And again, I apologize for the formatting of this. I'm not sure why the computer's doing this to me, but when they come in with those lower urinary tract problems, they most likely have been treated, medically managed for that problem somewhere else first and for an extended period of time. Typically, it's the primary care world that's prescribed the medications that they've been on. They've then failed those medications and show up in urology. They can be kind of categorized into two areas, either storage symptoms or voiding symptoms. On the storage side, it's frequency, urgency, and nocturia primarily. On the voiding side, it's a weak stream, intermittency, hesitancy, or they need to push, abdominally recruit in order to empty their bladder. And that, for the most part, can be attributed to BPH, or frequently, I should say, can be attributed to BPH or some type of obstruction in the lower urinary tract. What's interesting is about 50% of men by the age of 50 have BPH. And as the numbers go, 60% at 60 and so on and so forth. So there's a lot of men out there with BPH issues. Even though there's a ton of men with BPH problems, not a lot of them are getting treated. About 70% of the 18 million men over the age of 65 in America suffer silently. They do absolutely nothing about it. The balance, 25% of them are medically managed, so with medications, and again, outside of urology. And then of that group, only 4% actually move on to a durable intervention. And then you have the ultimate group that winds up with a Foley catheter as their treatment, or chronically catheterized. So for the most part, BPH is untreated here in America. There's about 400,000 procedures a year, deobstructive procedures a year are done. And that number's been the same for more than a decade, even though the population in this area has been exploding in this demographic. And there's reasons for that. It's a very difficult disease state to manage. So as you all know, there are big challenges in BPH once that patient does get into the urology office. The first is loss to follow-up. The patient shows up, they've been on medication for a period of time for their BPH or for their lower urinary tract symptoms. When they fail those symptoms is when they finally get referred to the urology office, when that medication fails. And now they walk in, and if that patient is just asked, what are your symptoms, and given a new script, or what they're currently on is titrated, you have a really high risk that that patient will be lost to follow-up, because either they don't take their medication, they don't take it properly, or they do take it and they have a side effect, and the patient just gets discouraged and they're just lost to follow-up. It's a very high number. Estimates are around 40% of patients are lost to follow-up, BPH patients, when they're just given a script and sent home and told to come back for a follow-up. So a very high percent are lost to that issue. The second is delayed procedures. Now, you do get the patient in the office, and every patient wants to delay. They want to hear that they want to hear their provider say, stop drinking coffee or change this behavior, and it'll solve your problem. The worst they want to hear is, take this pill. When you say that you need a surgery, the patient typically will put up a resistance. They want to delay for as long as they can. And then you get to this last column, which is unreasonable expectations. And that is, as a patient, if I finally do agree that I should have a procedure, I have an unrealistic expectation for the outcome. I've waited so long that my bladder condition has been compromised to the point where being de-obstructed, I'm not going to be able to return to normal bladder function or perfected bladder function. So I have an unreasonable expectation of what the outcome will be when I finally do get a de-obstructive procedure. So these problems are persistent. Everybody's got them with most patients that walk in the front door. And remember, typically about half the patients that walk in the front door to a urology office have lower urinary tract symptoms. So why do you do a cuff test? Well, the bladder has a life cycle. When we're young, and this graph here on the right-hand side shows you bladder pressure over flow rate. And when we have no resistance in the lower urinary tract, the bladder can both store urine inconsequentially without it being an issue for the patient. And when it's time to void, we void with a very low pressure at a high flow rate. And the system is great. And that green section represents low bladder pressure and high flow rate. Well, as resistance builds up in the lower urinary tract, either from BPH or obstruction of some sort, the bladder compensates for it. And there are a few key factors that change. Number one, we're all supposed to be able to empty our bladder in 30 seconds or less. As resistance builds up, that micturition time lengthens. The second thing that can happen is an increase in pressure. The bladder compensates for the resistance by squeezing harder. Well, as they squeeze harder, the pressure goes up, but the flow rate can stay the same. And you wind up in this top right-hand corner, which is high pressure, high flow, meaning there's lots of flow coming out, but too much pressure is required to get the urine out of the body. Over time, again, as the resistance continues to burgeon and restrict that flow, well, now you have high pressure in a low flow situation, which is that top left corner. And this is where your post-void residuals or remaining urine in the bladder starts to build higher and higher. Flow times get more and more extended. And then ultimately, if we do nothing about it, they wind up in what we call the low pressure, low flow, which is that lower left-hand corner of the graph, where you don't have enough bladder pressure or flow. And typically, you have a very compromised bladder at that point, a trabeculation, a thickening of the bladder wall, and an inability to store and evacuate urine out of your bladder. Now, medications can, for the most part in BPH, medications treat the symptoms. They don't treat the underlying condition. That's not true for all of them. There are some that will treat the condition as well. But medical management is really prevalent in this space, not just because the clinicians want to use medical management. It's because the patients want that too. The patients they feel like their best option is to take that pill. So for the most part, medical management is the predominant treatment for lower urinary tract symptoms, and will continue to be because it's the patient's orientation, and it's the lowest risk treatment option. And it's perfectly fine, provided we're monitoring that patient as they kind of go through that life cycle of the bladder. So as it relates to UroCuff, there are 4 primary ways or use models that the UroCuff gets used for. The first is a new LUTS. Patient presents to the urology practice as a new lower urinary tract symptom patient. The cuff test and a PVR are used to baseline that patient's health, that bladder health. The second is medical management. And this is kind of the design of the UroCuff. And that is to say, if I'm going to medically manage this patient with their condition, I'm going to use the UroCuff test to tell me what's the bladder health, how hard is the bladder contracting, what's the flow rate, and I'm going to watch that over time as I prescribe medications, titrate those medications, and ultimately decide at some point to move the patient to advanced diagnostics or a procedure. So that medical management is the big use model now for UroCuff across the country. The next is pre-intervention. So patients, before you do a de-obstructive procedure, you do a cuff test to help you determine what procedure is appropriate. And then lastly, there's post-intervention. Once I have done my de-obstructive procedure on a patient, I do an empirical evaluation with a cuff test to see, did it work? Number one. And number two, do I still need to use medications to perfect or improve the outcomes that happened as a result of the de-obstructive procedure itself? So those are the 4 primary use models of who you're doing it on, the most popular being that medical management. So what is the cuff test? Simply put, it's a non-invasive pressure flow. Imagine a UroFlow that gives you bladder pressure. We're going to put an attachment or an adapter on the patient one of two, and they're going to void into a uroflow, into a commode, onto a scale. And as they do that, we're going to, by watching the flow rate, be able to evaluate what's happening inside their bladder by applying resistance to their flow. It only takes minutes to perform. It's very simple. There's nothing goes inside the body, which the patients like a lot. And there's minimal or no discomfort, provided the test is performed properly. So it's simple and it's fast. Again, much like a UroFlow device. The UroCuff actually does standalone UroFlow as well, as a function of its system. But it's simple, it's fast, and should be with little or no discomfort to the patient. In terms of the science, it operates on very basic, like 9th grade physics principles. Pascal's principle says pressure is distributed evenly amongst a sealed circuit if there's fluid in that circuit. So imagine, if you would, the amount of pressure it takes us to stop someone's flow is exactly equal and opposite to the amount of pressure that it takes to create that flow. So if you see that poorly graphed example there on the right-hand side, that example shows 160 centimeters of water of pressure on the bladder, squeezing to get the urine out. And provided we have a column of fluid coming out, it's going to take us 160 centimeters of water of counter pressure to stop their flow. So it's quite basic science. How much pressure it's going to take us to stop their flow is exactly how much pressure is in their bladder. Now, we do need patients to be able to void to do this test. If they can't generate a persistent void, it doesn't work. So this only works for patients that actually are able to generate a moderate 2 milliliter per second or greater flow rate. But provided they do, we can tell you exactly what their bladder pressure is as they void. So the test only takes as long as to put the adapters on and have them void, and then take them off. So it's a fast, simple, painless way of determining the relationship between bladder pressure and flow rate. Now let's talk about patient preparation. You want patients to arrive for their test with a comfortably full bladder. That's a challenge, particularly someone with LUTS symptoms. If you say to the patient, Mr. Patient, I want you to come at 10:10 tomorrow with a comfortably full bladder, that could be hard if I've got frequency urgency or what have you. So you want them to arrive comfortably full, and you need to communicate that with them clearly ahead of time so that they can prepare properly. Most practices that have UroCuff programs call the patient the night before to remind them what their appointment time is, and to hydrate, and particularly hydrate prior to an hour before, complete 32 ounces of drinking so that you're ready to have that cuff test when you arrive. You want to encourage them in that regard. They don't have to change their medications that they're currently on. So you don't have to stop any medications prior to doing a cuff test. There's no prep in that regard. And you need to have good talk tracks. And Natalie, we'll talk to Natalie at the end of this brief presentation about what talk track she uses. But having a talk track for that telephone call ahead of time, and having a talk track for when the patient shows up to explain the test, those talk tracks are really, really important. We know in the community, and if you've done cuff tests before, that it's not painless and doesn't take long at all. But a patient doesn't know that. And whenever a patient's going to have a test on the lower urinary tract, they can be nervous. So having those talk tracks and communicating clearly with the patient what the expectations are really important to quell those fears. We also have a lot of tools that you can use, like you see there on the right-hand side. That's a prescription pad sheet that we have for the UroCuff test, that the front and back tell the patient how to prepare and give them some FAQs to again, give them an education and to quell their fears about how the test is going to be run. It also communicates to the patient what the urgency scale is. And we want that patient, it's very important that the patient come in with an urgency scale or a desire to void of 7 to 8 on a scale of 1 to 10. So you don't want someone to come in and say, yeah, I could go to the bathroom, because under that circumstance, they may not have the best bladder performance. You also don't want them to come in at the time for their test at a 10 where they're doing the pee-pee dance, so to speak, because then their performance could be impacted as well. So you want someone to say, yes, I need to void. And if I was watching the TV or reading a book or engaged in a conversation, I would change my behavior at this point and go to the bathroom because I feel like I need to urinate. And that can be hard for patients to obtain for a number of reasons. Either they have a clinical condition that makes it hard for them to obtain urgency, frequency again, Or they might get frustrated and not have symptoms where they know when their bladder's full until it's absolutely full. So they may get no warning. So this is a part of the test that is a challenge for a clinician to manage this and try to get that patient to the right amount of desire to void. Now, there's no minimum void requirement for a UroCuff test. In other words, a patient can void 50 cc's and leave 400 cc's behind in their bladder afterward. And can be a good test, provided it's representative of their normal micturition cycle, their normal behavior day to day. So it's what's important is that they have the right desire to void before the test, and that when after the test, you kind of query them to make sure it represents how they normally void at home. Okay, so now we get the patient in. We know they have a strong enough desire to void. They're standing in front of the machine. We have a choice to make. Which adapter are we going to use? This is a point of service decision. You can use the adapter on the left, which the adapter on the left goes up to the glands of the penis and the patient's going to void through it, and the instrument just puts resistance on the actual flow. Or you can use the adapter on the right, which is kind of like a blood pressure looking cuff that goes around the penis that as they void, that gets inflated by the machine until it cuts off the flow of urine. They're used, and again, we can talk about when to use each. But for the most part, I think people today are using the DC, as we call it, the one that's, as you see there on the left today. And it wasn't, the DC's only been around for the last few years. The classic cuff adapter, the classic as we call it, that was the first rendition of the device, and it is the most popular for hundreds and hundreds and hundreds of cuff systems that are out there today. Still use just the classic. So you have a decision to make on which adapter to use. Once you make that decision, you kind of hook the patient up. Now, there are, by the way, videos that are available to the patient. I just put these screenshots up there because the videos are very popular to give to the patient ahead of time, not when they come in for their visit, but ahead of time to let them know how the test is going to be run. And there are QR codes on all of the materials that we provide to the clinicians when educating the patient, so that the patient can just watch those videos at home. And that's been very helpful, we've found, or we've heard. So if the choice is to use the classic cuff, and in this circumstance, you may have a patient that has a phimosis, or you may have a patient that needs to sit to void, for example, and decide, yes, I'm going to use the classic cuff. So in the classic cuff, there's green writing on one side of that blood pressure type looking cuff that goes around the penis. You want to make sure that's against the skin, and you wrap it snugly like you would a blood pressure cuff, but you wrap it around the penis and connect the other end to the instrument. That's an air line, and it operates very similar to a blood pressure cuff. So that the machine pumps air through that air line and inflates the cuff as the patient urinates. It cuts off their flow of urine. Once it cuts off their flow of urine, it rapidly deflates. They start voiding again, and that process repeats itself until their bladder's empty. Conversely, you have this, what we call the DC, or the direct compression. We call it direct compression because we're only putting pressure on the flow itself. So that this device here, a small bit of lubricant is applied to the end of the device that's going to connect to the glands, or you can put the lubricant on the glands of the penis as well. And then you hold that up to the end of the penis. A gentle suction is created between the device and the glands. And then as the patient voids, the resistance, the device actually applies a resistance to the flow. And it operates on the exact same principle as the classic cuff, but by applying resistance to the flow, the instrument can inflate and deflate quicker, and we don't have to cut off the flow completely to know what the bladder pressure is. So this rendition of the device has become very popular because, for the most part, we never cut off people's flow unless they are low pressure, low flow. And in that circumstance, the software changes automatically to impact the flow as little as possible. And that was one of the design elements of this adapter, was to impact the flow as little as possible during the test. So this is, I think this is the preferred adapter that everyone's using today. Okay, now you've got the adapter, you've got the patient kind of set up in that regard. Now you put on some surface EMGs. Now, why would we need to put surface EMGs on? Well, we have no catheter in the abdomen, right, in the rectum or in the inside the patient to subtract ambient pressure outside the bladder, like in traditional urodynamics. So we put on surface electrodes on the abdomen to determine what the abdominal recruitment might be for that patient. Do they hold their breath and push, so to speak? So by putting the EMG electrodes on, we'll be able to see that. We're also going to put a set of electrodes on either side of the anus. And this is to look for any neurologic problems that exist in the pelvic floor, like dysinergia, for example, vesicosphincter dysinergia, where the pelvic floor is firing at the same time as the bladder and fighting against each other. So it's very important that these two sets of EMGs get put on the patient and connected to the machine. And they're just push connectors, so they're very simple to put on. Once those are on, you tell the patient, okay, I'm going to hit the start button on this machine, and you're going to void into that commode, and the test will be running. So you press start. On the right-hand side, I kind of have two samples here. You can see the green line at the very top. That's the pressure being applied by the machine to the flow. That's the resistance. So we slowly increase the pressure and then take it away, increase the pressure and take it away, so forth. The yellow line represents their flow and how that flow changes as we apply the resistance. The purple line that you see and the red line that you can barely see there at the bottom of that top graph, those are the EMG channels for that patient. So you can see what the graphs are on the right-hand side. We then can create from this test exactly what the bladder pressure or cuff interruption pressure looks like and what their urine flow looks like. The bottom example is someone who has, you can notice on the top example, the flow goes up and down quite a bit. That's someone who has a healthier bladder. This example I have here at the bottom shows that we're applying that counter pressure to the flow, but you can see the flow isn't changing much at all. So they have a lower flow pattern that isn't impacted much by our counter pressure, which is a classic behavior for that low elongated urine flow pattern. Is classic for a BPH or an obstruction patient. Could be a stricture, could be BPH, but some type of obstruction in the lower tract. So that's it. Once they've kind of emptied their bladder and they say, yes, I'm done, the system will either end itself when it sees a lack of flow on the scale, or you press the end button. And for the patient at that point, it's over. So after the test, if you use that DC device, that direct compression, there could still be a suction happening to the glands. So you can break that suction, either the patient can with their thumb, or you just disconnect the vacuum line and the device falls off. You then need to do a PVR. Post-void residual is critically important to the analysis of this data. So you immediately want to do that PVR. And you want that PVR, it's most appropriate if the PVR machine is ready right after the test. You don't want to have to room the patient somewhere else in the practice or go find the PVR machine to do the PVR after this test. So it's important for efficiency perspective. You want to be able to do that PVR immediately in the same space that you did the UroCuff test, as if possible. You then want to ask the patient, do you feel empty? Do you feel empty now? And do you typically feel empty normally after you go to the bathroom? Was this a typical urination for you? Is this any different than you normally void? Other than the fact that you're in a strange environment in a urology office voiding into this machine. You want to identify for the provider and for the reporting, that the patient, what their belief is. Do they feel full now and they normally don't? Do they feel empty now and they normally don't? You want to note any of those things for the test. And you want to enter those notes into the instrument before you print the report. If they still feel like they're full, there are times that a patient might say, no, I still feel like I'm full. And typically when I'm at home, I have to go twice. I double void. Well, in that circumstance, we frequently will hit print on the report and turn on the standalone UroFlow and let them void again right there so that we can collect that data because that becomes very valuable data for the provider. And you scan them both times. You scan them after the PVR, after the UroCuff, as well as after that UroFlow, so that the provider knows this is what's happening with this patient's normal cycle. So again, as with all urodynamic tests, our goal is to replicate what happens at home and put empirical data to what happens at home for that patient or in their normal life. So we're doing so in a very foreign environment, and our environment and the way we test with urodynamics, and of course with tests like this, it impacts that system. It's not natural. So you want to make sure you collect that data from the patient subjectively after the test and note that for the provider who's going to be interpreting and determining the care pathway for the patient. So at that point, you've entered the information, you've disconnected the patient's done, you've scanned them, you just print the report. And the report that comes out, although it's quite simple to read, there's a ton of data that comes from it. It's multiple page. It's a 2 or 3 page report, depending on what version of the system you have. The first page is great for communicating with the patient because the patient can easily understand that nomogram on the first page where the green is good and the red is bad and the X is me. That nomogram doesn't always tell the story for the provider. There's typically more to evaluate inside that data set, but it's a good communication tool with the patient, that nomogram, because again, it's intuitive for them in terms of understanding the results of the test. One of the other beauties of this test is that if you are medically managing someone and you do cuff tests incrementally, where you start them on a medication, you do a test in 60 or 90 days to evaluate the performance of that medication, and then you see that patient every year, the cuff test, you can print a report that shows the progression of that patient test to test to test. So on one page, it will show you how the patient's performance is for the last 3, 4, or 5 cuff tests that you've done. And that's a nice way of, again, looking at it clinically and communicating with the patient clinically what's happening with their condition and the progression of their condition. Now, a quick note here on locations for the cuff machine. It's important. A cuff machine, because a cuff program typically has its own schedule. So patients are scheduled for a UroCuff test on a separate provider schedule, typically. And it's 5 days a week, it's 3 days a week, it's 1 day a week, maybe it's just a morning a week, however many slots you need. It's on its own dedicated schedule. And those patients are on a short schedule. They're 15-minute visits typically for a UroCuff test. So they're in and out of the practice quickly. So you want to pick a location for a UroCuff system that is close to the front of the office. It can be in a patient room, there's pluses and minuses to each location you pick. But it can be in a patient room, it could be located in a restroom, it could be mounted to the wall, it could be in a procedure room. Our least favorite is a procedure room because you're tying up that procedure room with a cuff test that only takes 10 or 15 minutes beginning to end. You can put it anywhere in the office, but the most popular now is either in a large restroom or in a patient room. Okay, on best practices, I thought we'd end this today with what's of the big UroCuff programs, and we have associated urology specialist staff here today to answer questions. They've got a big UroCuff program that is a programmatic, a protocol-driven program for the practice. And we've learned what's kind of works and what the best practices are for successful programs. And these are some of the key elements to a very successful cuff program. Number one, you got to have a protocol. Having cuff tests done in the middle of the day randomly on patients as the provider sees them tends to be chaotic for a practice. So having a protocol-driven system where the staff knows exactly who the provider wants to test, with what clinical condition, and what urodynamic parameters that patient has. Letting everyone know that and having the practice running on a protocol is the smooth way to run a cuff program versus randomly picking patients through the day and trying to get that patient with a full bladder during the day randomly on a schedule. It just seems to be not the most successful way to do it. So protocol-driven programs that match the resources of the practice are key to a successful program. Next, and of the last few years, kind of one of the biggest elements is APPs. Physicians, urologists have decided that having the APP manage a BPH patient is a preferred method for managing that patient through their care. So APP-driven programs have gotten very popular over the last several years and are growing every single day. Patient identification and triggers are critically important to the provider, meaning define your protocol, and then once you identify those patients that are coming in next week, for example, have an identification for that patient of providing them information when they're roomed, so that when the provider walks into that treatment room to interact with the patient, they know, yes, this patient meets my protocol. I'm going to have them schedule a cuff test on their way out. And have a trigger, like I said, materials or what have you, to trigger that provider to know that the patient meets the protocol that they've designed. You got to have dedicated testing staff for cuff programs. We say dedicated because, the average urology office, if you've got 2 providers, they're going to do at least a couple days a week, full days of UroCuff tests. And having it randomly done by the staff can be chaotic. So having dedicated testing staff has definitely become a best practice in cuff programs. People that just do rooming of patients and cuff tests has become very popular. And oddly, having that dedicated schedule with 15-minute blocks for cuff tests is the smoothest way to run a cuff program. And we'll talk, we can query Natalie and Sarah about this, who are on this panel. But having 30-minute schedules or longer appointment times tends to be more chaotic and more stressful on the practice when doing cuff programs. Because it's difficult for a patient to show up at an exact time with an exact desired void or volume in their bladder. So when that patient checks in, the very first question to that patient is, how full do you feel? Do you feel like you have to void? If the patient says, no, I don't feel quite full yet, the answer is, sit down, have a drink of water, Mr. Patient, and we'll bring you back when you're full. If you're running 15-minute scheduled blocks on your schedule, you just take who the person is who's next. And inevitably, one of the two people in the next 30-minute block that you're dealing with on the clock is ready at the appropriate time, and it doesn't slow down the people that are actually running the test. So having a dedicated schedule with 15-minute blocks is definitely a best practice. So that said, that's the end of our slides from the clinician's perspective on the UroCuff test. And we do have a couple of people here today, Natalie and Sarah, that are running very busy UroCuff programs that have been around for years now. So they can tell you the good, the bad, and the ugly. They're good people to ask questions about running a UroCuff program for sure.
All right. I'm going to just before we get to your speakers, there was some good questions that came through. I thought I'd go ahead and address. And hey, John, welcome to the show. I'm working on this mobile system. I didn't see him sneaking on the bottom, so I didn't bring him in for the early introduction. But I'm going to go ahead, though, and bring in some of these questions from the audience first. So this one Johnny actually gave here was, how will SRS medical assist urology practices as urodynamic procedure payments are slated to decrease by 15% in 2025?
Boy, that is a great question, and one that when we first started SRS 35 plus years ago, we didn't have a reimbursement department at all. I mean, we had engineers and we had manufacturing, and that was it. We didn't even think about reimbursement. Over the last 10 years, we now have like a staff of people that work in reimbursement, that work with the AUA and talk with CMS. And as you know, the RUC this year is reevaluating the 5 series codes, which are all the urodynamic codes. So we have a persistent relationship with them that by the way, goes MAC to MAC to MAC around the country. We provide information upon request. We provide it even when it's not requested. We've worked with individual MACs over the last 3 years where they didn't have coverage for UroCuff identified in their LCDs. And we worked with those, our reimbursement department worked with those carriers to develop coverage policies and publish them. So we are far more active than we ever thought we would be in reimbursement as a manufacturer, which is unique to us. But we are absolutely dedicated to making sure that reimbursement is maintained for all urodynamic. We make urodynamic instruments as well, catheterized urodynamics. So we are intently interested in maintaining the reimbursement level and improving that reimbursement level where possible, and continuing to improve the technology, of course, to make it more efficient to use. But we're dedicated to that support, and we have on-staff support for it to help both with coding and with claim submission. And we'll have no intentions of changing that, and we'll continue to do so for the foreseeable future.
All right, great. Some other questions here. Christian Tech, the patient preparation is similar to a simple uroflow. I guess the question is it similar to the prep for a uroflow? And any of your experts that want to take it, just give me a hand up and I'll.
Natalie, how do you have the patient present or prep?
So I have my schedule, and then the day or two prior, I will call them just to remind them, make sure, like in the slide, come in with a comfortably full bladder. I do offer patients, if their appointment's at 9, they want to come in at 8:30 to drink more water, that's fine. That way they're there at the office ready once they have to go, because sometimes over the phone, they're like, well, I have trouble holding it. So I'm like, that's fine, come in. Even if you're not ready, at least you're at the office once you are ready. They drink the same amount of water. The front desk will let them know, hey, or ask them, are you ready? If they say yes, they'll come get me. I'll bring them into the room. I re-ask them, hey, how you feeling? Do you feel like you have to pee? And based on their body language, how they respond, I will perform the test. If they're like, yes, I'm ready, I'm like, okay, let's waste no more time. If they kind of give me kind of hesitate, I'm like, okay, let's maybe scan your bladder first, see what you have in there. And then if it's not quite enough, or if they're just not quite, I'll try, or maybe, okay, let's have you wait a few more minutes. I'll come check on you, and then we'll go from there. But I would say, yeah, same preparation, full bladder. That way, once they are ready to go, they are able to go. And so that way the test is accurate and gives us good information for the doctor.
Vic, if I could add to that. So for catheterized urodynamics, most providers say, if possible, I'm going to change or get patients off medications prior to doing a urodynamic test, a catheterized urodynamic test. This is much more like a uroflow on that spectrum. So no one really changes a patient's medications prior to a cuff test. It's really seen like a free flow, like a simple uroflow. So it's quite different than catheterized urodynamics in that regard.
All right, good. We had this is not the one I was trying to get. Here we go. Susie Swain, can MAs perform this test? Somebody want to take that?
Sarah, can MAs do it?
Yeah, Natalie is a medical assistant, and we're actually hiring another medical assistant to join our practice to do just the cuffs. A nurse can obviously do it as well, but it is definitely within the scope of practice of a medical assistant.
And that's most popular. I think it's MAs really across the country that are doing them for the most part.
They have more time outside of the other nursing responsibilities that we have to spend more time with the patient to explain everything and dedicate a whole day to just doing cuffs.
All right. And Lori, I saw you had a question sneak in there. And since you're here, why don't you go ahead and present it?
Yeah, I did. So we have a UroCuff in our office only because it came with another group that joined our practice, and it's been sitting on the shelf. And one of the problems that they had was that it would fall off. And so I was wondering, are there different sizes? What are the tricks to trying to keep it on?
Oh, it's a great question, Lori. So there are different sizes, although honestly, the standard size, I'm going to presume that it's classic cuff. So the machine that you have is one that only uses this. And it is a limitation, the fact that it is the size that it is. And when I say that, if someone is too small, if the penis is too small, there are times when this is so small that you can't. But even with an index finger, you can get it on snug enough. But there are times when a patient doesn't have enough physical mass in the penis to use a classic cuff. And I don't want to underestimate that. Natalie, how many times can you not get a UroCuff test because of the physical anatomy of that patient? What percent?
I would say in the couple thousand that I've done, I've only run into maybe one or two. One was as of recently, he was just very uncomfortable. And I was like, okay, that's fine. But I would say not often at all do you run into an issue of size is an issue.
So I would also say, Lori, that people have a tendency of being like shy with this. It's like a blood pressure cuff. It doesn't have to be exact, right? You wrap it on, you want it to be snug. I get a lot of people who will say, how snug? I need to know exactly how tight. It's like a blood pressure cuff. You want it to be snug enough so it doesn't fall off, but not so snug that you're cutting off the blood flow, right? So you can be quite general with it, and you're going to get the same accuracy from it. But in terms of falling off, it shouldn't fall off really under any circumstance if you get it wrapped around snug enough.
Natalie, you did UroCuff Classic for about a year prior to DC being introduced into your office.
Yep.
Were you putting it on the patient for him, and did you have issues with cuff? Because I know you still do them once in a while when you need to for the patient.
Every so often. It's not often at all anymore. Because even when they sit, I still use the DC cuff.
Good, cool.
Mm-hmm.
when you did do UroCuff Classic, did you have that problem too, where it was hard to get that cuff on the patient?
Yes and no. I would say the new device is much easier to get on, but I would say it was still all right to get on. I would put it on myself. I wouldn't have the patient do it. But I would say no, like David said, as long as you put it on just snug enough, but not too snug, it shouldn't fall off. And I would even have them kind of hold it just ever so slightly, again, just to ensure that it doesn't fall off. But I wouldn't say I ran into too many issues that I can remember when using the classic cuff.
Thank you.
Yep.
All right, great. I do see another question coming in. I call US who perform Uroflow and other similar tests Uroflow coach. So there's a comment on that. I guess that would make sense.
Coach or a champion, Vic? We hear champion a lot. I'm the UroCuff champion.
There you go.
If I'm the clinician. Yeah, I hear that quite a bit.
It's all titles. John, I'm going to bring you up here since we didn't get to welcome you to the show formally during the start. You have any comments, questions, thoughts on this?
No formal introduction necessary. I'm a frequent visitor to this presentation. So, David,
Yes, sir.
I love your response. You answered it like a politician. I almost called you Trump, Biden, or Harris. dancing around reimbursement. But we will see what SRS does with the cost structure of the DC or the cuff once 2025 payment rules come out. One very important question is that for practices, knowing the benefits of the newer model machine, for practices that are running the classic, is there an upgrade path to go from classic to DC? Because clearly DC is much better, much more convenient for the practice in terms of workflow.
Yes, there absolutely is. When we designed this this adapter, we had the upgrade path in mind the entire way. So we just have to swap out one box, the gray box on the instrument, and update the software. That's all we have to do. It operates on the same computer. Everything else remains the same. And we kept that in mind as we did it, because there are 500 or so classic devices before we even brought this out across the country. So yes, there is an upgrade path to do that. And most people do it once they see this. This is easier for the clinician, though we don't want the clinician to hand this to the patient and say, put this on. It may seem intuitive and simple like that, but you want to make sure the urethral meatus is centered inside that cup. If it's not, the device can't operate properly. So it's intuitive, but we don't want you to just hand it to the patient. But because of its design and only putting resistance on the flow, it's better for the patient, it's better for the clinician, and we get about twice as many data points in the data set to analyze. The system does. So there's a lot of benefits to this, and there's an upgrade path for everyone to do it. And once you're upgraded, you can use either one each time you do a test. You can shoot a barcode on this versus a barcode on that at the time of service, and the instrument automatically knows which one you're using.
Yeah, we jumped right in as soon as I saw that the DC model was available. It was a no-brainer.
Yeah. Yep. I've done hundreds of tests on both myself. I'm definitely a fan of the DC.
Talk about a live demo, huh?
Yes. We have a lot of employees that have literally hundreds of tests in our database. It's part of our own research. We do it internally.
I had one question during your talk. You'd mentioned that you could have somebody give as little as 50 cc's of urine to get a test. And as somebody who's done a lot of urodynamics, and the urodynamic groups typically say that you should have about 100 cc's to get a proper flow rate. So I'm wondering, how do you know that that's accurate or not?
So that's a great question, Vic. I mean,
whichever expert wants to take it.
Yeah, I'm old. So in the old days, we were taught you got to have 150 for a free flow to be accurate, right? That's what all the old literature said. So with a UroCuff test, it's kind of interesting because with the DC in particular, we're applying pressure quickly, 1.5 seconds up and then 1.5 seconds down. It's a 3-second cycle. During that cycle, we can tell what the bladder pressure is. So as long as someone has a persistent void, 2 milliliters per second of flow or greater, we tell them 2 cycles or more for 6 seconds, You could actually have someone with 20 milliliters voided, and we can tell you what their bladder pressure is. Now, we can't tell you it's their best, right? We can only tell you what the bladder pressure is for the time period that we evaluated. But there are a lot of patients that'll come in, they void 50, but they leave 350 behind. So their functional capacity is 400, and that's clinically reasonable, right? 300 to 500. But they can only void 50, and that's their condition. That's the reason why they have urgency of frequency. So we like Natalie said, if someone comes in and says, yeah, I could void, she'll scan them ahead of time. And as long as she's seeing a reasonable volume in that bladder, she'll do the test. And if they only void 50, the next very important question that the provider needs is that normal for you? If the person says yes, then they should be telling you on their IPSS, I'm voiding 12, 14, 16 times a day, right? So it's a confluence of things. We're going to be able to tell you at a very low volume what the bladder pressure is for that volume, which means there's data that's coming from the test. Is it the best test, Vic? If you void normally 100, then we want you to void normally. We want you to void 100 when you do this. But we're going to give you data in any circumstance, provided you void about 20 cc's for more than five seconds. As long as you do that, we're going to be able to tell you what bladder pressure is for that void.
So pressure would be something you can get from the test. Uroflow is not going to be accurate with 50 cc's.
Unless that's normal for them. If that's the normal behavior for that patient, then I would say that's a great test. If you void 50 and you keep 300 behind, or if you have a clinical condition that's compromised your storage capability, then that could be a very clinically valuable test that's actionable for the provider. The key is it has to be what's normal for that patient. So everything else has to line up. If they're not telling you they have nocturia 3-4x and they void 75 cc's, no, then you didn't get a good test because that patient should have frequency that is significant in their day-to-day life. They should have nocturia that's significant in their day-to-day life. So you kind of have to bolt these ancillary items on, just like you do with a PVR. Cuff test, I think, is great data, but it needs the PVR to get, the more you bolt on, the more this data becomes valuable in developing the clinical pathway. Anything you take away from it becomes compromising. So that low volume test could be very valuable and clinically accurate, provided all the bolt-ons kind of support what you found.
Hey, Vic, to answer that for a second, David, sorry, but the UroFlow, in a UroFlow with a low volume, in just in a low UroFlow, you're looking for a pattern, you're looking for time, you have to have a decent amount of urine to get the flow pattern itself, plus the voided volume in the PVR. And that's why it's, especially if the patient isn't urinating much, the bladder pressure, having the UroCuff, we're giving you the reason other than that flow pattern, right? Because doctors are used to using the flow pattern to, decide whether there's obstruction or not. Whereas, the UroCuff itself, you can have even a great uroflow and still be obstructed. So again, just sorry on my tangent here, but that's kind of how I see it is the UroFlow. I do think just standalone UroFlow, it's not very helpful to have a 50 cc UroFlow.
Right. Sure is.
Yeah. So.
And I know there's a number of us in the audience that do urodynamic. So we're always kind of comparing these other procedures. Far less invasive to be able to do a test like UroCuff instead of putting, a catheter in the bladder, a catheter in the rectum.
But anyone
void normally.
Anyone in SUNA though, Vic, we would love to put catheters in everybody in the lobby, right? It's the best way of doing, of getting all the data that you want. It's just not practical. The cuff was born and developed out of the wait time to get a urodynamic study over in Europe. It's like they were waiting 9 months before they could do their TURP because that's how long it took to get a urodynamic study. And they said, no, we need something simpler and faster like a UroFlow. But a UroFlow is not enough, right? So we all want to put catheters in. It's just not practical to put catheters in everybody, which is why people do the cuff.
Sarah, what's your wait time for urodynamics right now?
It depends on the office, but it's about 2 to 3 weeks.
That's not bad.
What's your wait time on UroCuffs right now?
A week, depending on the office. If that, you can ask Natalie, but there's probably openings, next week. Or if somebody had to be added on, then Natalie would just add them in.
I would say about a week. Yeah, about depending on the office, I would say yeah, if a week, even if that, like we'll have patients, doctor will order it one day and then they're coming in that same week to do it. Just we want to get them in. We leave the day open and I'm there. And sometimes they'll add on patients that same day, like, hey, this guy has a full bladder now. Can you do his UroCuff? Absolutely.
And that's
the average private, sorry, Angie, the average private urology practice will do, 10 or 12 or 15 urodynamic studies a month. Whereas with a cuff test is more like a flow test. They'll do multiple times that many cuff tests. And the cuff does not replace urodynamics. I mean, we don't want to disparage your catheterized urodynamics here at all. There are times that you'll do a cuff and you'll say, you know what, your symptoms don't match your cuff test. And it looks to me like you've got a neurogenic issue. I need to do a storage test on you. I need to do full urodynamics as a result of doing the cuff. That's not really common, but that happens from time to time, particularly, based on that, the neurogenic community, which is growing over time. So yeah, we don't want to say anything disparaging about, we love catheterized urodynamics. We'd love to do it to everybody. It's just not practical.
I have found too that a lot of the low flow, low pressure patients, when they have a urodynamics test, because whenever I see a patient void 50, I'm like, oh, that's not a good test. And I get very frustrated, but then they'll go on to a urodynamics and it'll say patient has a small capacity bladder. And that just goes to show that the UroCuff test was accurate, even though they only voided such a small amount.
That's just the way they void.
Right. Mm-hmm.
And just to give you some context, anecdotally, we have 11 scheduled this coming week, UroCuff procedures, and I'm a solo practice provider. And I just sent my office manager about the scheduling, and we need to make some adjustments after hearing the best practices. And speaking of best practices, I think it is very important for everyone to know that no matter what technology you're bringing into your practice, whether that is OAB, whether that is in-office dispensing, or UroCuff, getting everyone on board is extremely important. I also like the hot tips that you gave at the very end, calling the patients beforehand to remind him of what to expect, the use of the prescription pad at the time of the scheduling to set expectations, and then having a set talk track, and also the QR code leading to the video so that the patient's well-versed in what to anticipate at the time of the visit. Back to you, Vic.
Yeah. I just wanted to thank David for this presentation today. It really spoke to me as a nurse practitioner, because in our practice, we have many nurse practitioners and many surgeons, and our APPs do most of the medical management for those patients, and we do a really great job for that. Yeah. And speaking of best practices, I wanted to take this opportunity to remind our audience, we've got people who work in urology at all different levels. The biggest concern for these patients over time is if they ignore it, they let things go, their bladder can stop working. The bladder is actually a muscle and it should squeeze to empty the bladder. And if we're not clear about that and communicating to that to our patients, they may be lost to follow-up and end up with a bladder that no longer squeezes to empty. So all of us have that opportunity to remind the patient that they need to be seen at regular intervals.
And this
so I just wanted to share that.
And this is something I told the patient yesterday who is reluctant to undergo any sort of intervention. I said, sir, I've seen this movie play out many, many times. I've seen the same movie for a long time. It always ends up the same way. You'll probably end up in the emergency room. They'll put a tube into your bladder and you'll come running back in here asking me to take care of that problem. And I'm going to turn around and tell you, I told you this was going to happen. Back to you.
Yeah. And I think all of us in urology have had that experience where a patient comes in and they have an atonic or a hypotonic bladder, and procedures, it's too late to do anything. So it's just one of those things that getting this information ahead of time is really important. I'd like to say this has been a great discussion. Really appreciated having you guys join us for this. As all tests, there's good things about every one of them and downsides to all of them. Mm-hmm. We never do a urodynamics test that I've never had a patient who couldn't urinate because they were too shy to urinate with another person in the room. Mm-hmm. So I think sometimes the UroCuff could add more privacy and the ability to maybe get a better study. So lots of options out there. It's really good to be able to share those. With that, I have a clip for next week's show.
This activity is designed to provide the urology team with the latest developments and critical insights into bladder cancer management. To help ensure optimal patient care, this activity will provide clinicians with a comprehensive understanding of the appropriate diagnosis and risk stratification of patients with bladder cancer and the clinical utility of immunotherapy agents that could significantly impact patient outcomes. Identifying and treating adverse events likely to affect the majority of their patients being treated with immunotherapy will be discussed. This activity is supported by educational grants from AstraZeneca and CGen and is eligible for 1 contact hour or CME. Join us next Saturday to learn more at uronurse.com.
Hey, and for any patients that are out there, don't forget the UroPatient podcast comes up at 10:30 Central Time. And I'm just going to put a quick reminder in that if you're interested in learning more about podcasting and doing something like we're doing right now, coming September 4th, boot camp, where you can be on the show and learn how to use the show, but we're not broadcasting it anywhere, so you don't have to worry about goofing up. Once again, great panelists. I think this is the largest panel I've had for this show, so it's really been kind of neat. It was fun. It really was well organized. Everybody really got, I think, to get their say. With that, though, I got more vacation coming up to visit more places, and I appreciate everybody joining us today. And we'll see everybody next week. Have a great weekend, everyone.
Thanks for having us.
Bye, everyone.
Thanks. Bye.
Thank you.
Vic, appreciate you putting on the program while on vacation.